Thank you, everybody, for attending our COVID-19 Impact on Stroke Care Lunch and Learn Series webinar. We still do have a few late-minute signups, so I'm trying to stall just a little bit. My name is EJ Andrews. I do marketing for TeleSpecialists, and we are very excited and happy to have you here for our first Education Advisory Council presentation presented by TeleSpecialists. Dr. Behravan and Dr. Sevilis, are you on?
I am.
Great.
Yes, I'm here.
Great. We are so happy to have you two presenting our first webinar. I've worked with these two doing other COVID projects. We have a video on YouTube as well. So they know so much about this subject, and we're very excited. So let's start with the introductions. Dr. Vahid Behravan is joined TeleSpecialist in 2018 as a teleneurologist and has since taken on the role of Director of Clinical Research. He graduated from medical school in Iran with a neurology residency at Kansas University and a fellowship in neurorehabilitation, and is board certified in neurology. In his free time, Dr. Behravan enjoys painting, calligraphy, photography, music, and weight training, and lives in Maryland with his wife, 2 dogs, and a cat. Dr. Theresa Sevilis is double boarded in both neurology and vascular neurology, having completed her vascular fellowship at UNC Chapel Hill. Dr. Sevilis joined TeleSpecialists as a teleneurologist in 2017 and became a regional medical director in January of 2018. She attended Midwest University for medical school and currently lives in North Carolina with her husband and 2 children. Thank you both so much for joining us today.
Absolutely. Glad to be
All right, let's get started.
All right, I'm Dr. Behravan. I'm glad to be here with you guys, and thank you for taking time to join us in today's Lunch and Learn. I know you're going to be very, very busy on Mondays, and thank you for being at the forefront of basically dealing with COVID pandemic. I have no relevant disclosures regarding this presentation. Next slide. So just, quick points regarding this pandemic. WHO declared the pandemic on March 11th. Now we know that it had been going on for a long time before that. Now even some studies put the concern that this has been going on late 2019 and sometimes even before China declared their infections. Now, the neurological presentation, this study in this pandemic is not uncommon. It's actually, at least based on one study, seen in 36% of the patients. Now, other studies do put the number either lower or higher, but just based on the study that came out of Wuhan, dizziness at about 17%, headache in 13%, impaired consciousness in about 7.5%, and stroke 2.8% in their study, even though we're going to go through the numbers that has been seen in higher numbers too. Impaired taste and sense of smell, one of the very early signs that were reported early on, and then injury to skeletal muscles, 10.7%. There's some other studies that report that agitation, psychiatric presentations have been also seen with COVID pandemic. Now, so far we know that the neurological symptoms are more common in patients with severe infection. About 45.5% of patients with severe infection, COVID infection, demonstrate neurological symptoms. And in non-severe infection, it's still present, about 30%, again, based on the study that came out of China. Now, there's a pooled analysis came out of, analysis of 4 studies that showed stroke itself increased the odds of severe COVID-19 infection. about 2.5-fold. So when someone had a stroke, the possibility of having severe COVID infection was 2.5-fold. So it's kind of a two-way effect that we see, even though at least based on that analysis, it did not increase mortality, but there are some other reports out there that it can affect the outcome as well. Next slide. Now, more about the impact of COVID-19 pandemic on particularly stroke care. First of all, we know that whether you have the infection or not, it's going to affect your medical care because some hospitals are overwhelmed in hard-hit areas with the COVID cases. So even if you have, let's say, chest pain or shortness of breath for a different reason, or completely non-respiratory related issues, the care that you can receive would be affected by this pandemic. And then, of course, if you have the infection in hard-hit areas, sometimes it's difficult to get appropriate medical care. And the other very, very important fact to know is that strokes will still happen. Whether there is COVID pandemic or not, strokes do happen. But one interesting fact is that we've seen that the numbers of strokes, whether the alerts that we receive or the proven facts, has decreased. And this is across the board. This is, multiple regions, multiple countries. They've all reported decreased in stroke cases. There are multiple theories that Dr. Sevilis is going to go over them, that, why we see this. But it's an interesting fact that has been noticed and has been reported, even sometimes up to 50 or a higher percentage decrease in reported stroke cases. And another obvious fact, but it's important to notice that having the COVID-19 infection is not a contraindication to receive stroke care. Now, it does change, what we can offer depending on some lab results that we're going to go over, but it does not, it's not a contraindication to receiving IVTPA or endovascular treatment. Next slide. So the changes that we see, first of all, it's very, very important that if you're in touch with the community, if you have the opportunity to educate the community, still emphasize on the Be Fast, having just an early way of recognizing stroke symptoms, balance issues, eye movement issues, and changes in face, facial droop, weakness in arm and speech, and then emphasize on still calling 911, still presenting to the hospital, even if you have fear of COVID infection. The slogan, the stay safe at home. If you have a stroke, staying at home is not being safe. So if you have stroke symptoms, you have to call 911. You have to come to the hospital, because we can't help, we can't protect you against COVID in the hospital. But if you stay at home with stroke symptoms, you're not getting the appropriate care. So it's very, very important to emphasize on presenting to the hospital if you're experiencing stroke symptoms. Same thing goes with chest pain that's concerning for heart attacks. Now, in the hospital, what needs to be done, and I know that almost everyone is now have dealt with these issues in their facilities already, but we have to minimize the exposure for both patients and the medical team that is dealing with a stroke patient, whether they have COVID symptoms or not. Now, we have to provide a quick, very effective and quick evaluation and treatment to the patients, whether they have COVID symptoms or not. There is an increased risk of exposure to COVID-19 for healthcare providers. We know that because of the time that you spend in the ER or in the hospital, and then the amount of interaction that you have to have with the patient, especially in the ER, and sometimes sick stroke patients. And we all already know that many of these patients can be asymptomatic. So it is wise to consider, especially in hard hit areas, to consider everyone a potential COVID carrier, even if they're asymptomatic when examining and dealing with the patient. Now, for the immediate assessment of stroke severity, we do use stroke scale, and we determine whether they're IVTP candidate or thrombectomy through our examination. And teleneurology has been shown to be equivalent to bedside assessment, multiple studies. So now many hospitals that did not have teleneurology, telemedicine before are basically going to that way, requesting teleneurology services to both protect their providers and still providing a very, very quick and reliable assessment for the suspected stroke patients. Next slide. So this is a quick algorithm, and this is based on the guidelines that provided that when an acute stroke patient comes in, whether they're confirmed or suspected or even asymptomatic patient, we have to have early identification and separate the confirmed cases. So in the ER, if possible, we're going to go over that. If possible, the route for evaluating stroke patients should be separate, again, logistically, if it's possible, if the ER has that ability, so we can decrease the cross-contamination. But if someone is a highly suspected or a confirmed case, then it has to be determined, whether they need to be in the more COVID exposed area, because we don't want to contaminate the stroke area or the stroke room assessment. And then telestroke is extremely, extremely important, especially these times, because it reduces the exposure and it can still provide a very quick assessment. Now, just like any other COVID infection presentation to the ER, we have to consider other organs being affected, liver, kidneys, so appropriate labs should be sent early on. We do send these labs with every stroke alert, but it becomes even more important because of the changes that we can see, especially in coagulation panel, that's going to affect our decision making for TPA. Now, regarding the CAT scan, so basic non-contrast CAT scan of the head is done in every stroke patient, but in some stroke patients, we do the CT angiogram if we're suspecting large vessel occlusion and CT perfusions, which require contrast. And, we're going to discuss this, that in suspected COVID patients, we may reconsider this, and we're going to go over it, that why this may need to be reconsidered. And then regarding the TPA, again, COVID infection itself is not a contraindication. So even if it's a confirmed case, IVTPA would still be considered. Same with mechanical thrombectomy, and we're going to go over some caveats regarding the mechanical thrombectomy cases as well. Next slide. So what we need to do, we have to minimize the number of members of the stroke evaluation team. Now with telestroke, it's already done to a degree, but before COVID, we had many nurses in the room available, and one would help with our assessment in the parts that would need someone in the room to assist with the stroke evaluation. And then parallel to that, lines were getting done, and anything else that the patient would need was being done by multiple staff in the room. Now we have to minimize that, and everyone in the room should have a PPE, depending on the facility and depending on their own protocols. Now that PPE would be anywhere from a surgical mask to full protection, and then the distance should be still kept if possible. Now, for some elements of the stroke evaluation, we need someone close to the patient, checking the sensation, checking the extension. Those would need someone very close to the patient, but when possible, we can do it with telestroke cart and keep the distance with the patient. As I mentioned, it's better to have dedicated stroke room evaluation to avoid cross-contamination. And then we consider nephropathy. This is one of the other points that was important in that algorithm, that COVID patients can have nephropathy. And if it can be avoided, it's better to avoid early CT angiography if it's not necessary. So if the symptoms are mild, we don't really expect large vessel occlusion. It's better to avoid CT angiography, and then later on routine vascular testing can be done to avoid the additional pressure on the kidneys and potentially avoiding nephropathy. CT chest has been proven to be a valuable tool for detecting, confirming COVID cases. Now, we can consider low-dose concurrent CT chest. Patient goes to radiology for the CT head and sometimes CT angiography. So if the suspicion is high, we can do a very quick low-dose CT chest to help with the diagnosis of the COVID-19 and basically decrease the risk of going back to radiology later on. So that has to be considered early on. Now, another problem that is seen with COVID patients is the coagulopathy. And that is something to be considered when we're considering IVTPA. So the standard is before COVID-19, we do get the coagulation lab, but we don't wait for them to come back before giving IVTPA unless there was a very high suspicion of some sort of a coagulopathy in the patient. But now, with the cases of low platelets or other coagulopathy seen with COVID patients, if there is a high suspicion, we would wait for the labs to come back and make sure that patient will meet the criteria to get the IVTPA. The same thing applies with hepatic dysfunction that is seen in these patients with or without coagulopathy. So it's something to consider in especially highly suspected or confirmed COVID patients that come with stroke symptoms. Next slide. Now, mechanical thrombectomy, again, having the infection is not a contraindication to having mechanical thrombectomy, but because they have to go to angiography suite and some of them would require intubation, it has its own precautions. So we know that there's going to be some delay in the hospital-to-hospital transfer if the initial hospital is not the center for thrombectomy, and this has to be anticipated. So if there is a high suspicion for large vessel occlusion, we think that patient would be a thrombectomy candidate. It's important to contact the receiving hospital early on because some delay would be anticipated. And it is important to be proactive in obtaining consent. So this issue, especially now with many hospitals having the no family member rule or no one accompanying the patient in the ER, has created delays when there is a need for consent, such as mechanical thrombectomy procedures. It is reasonable to consider everyone needing the mechanical thrombectomy as COVID positive because, again, there is a very lengthy and close encounter with that patient with potential needs for intubation. So it is reasonable to consider those patients COVID positive and dealing with it as such. It is recommended that if a hospital does conscious sedation, it is better to keep the patients in that state. But if there is any suspicion that this patient may need intubation later on, it is recommended that the intubation is done earlier. So we can protect the angiography suite team and the staff from potential COVID infection later on. That said, again, if conscious sedation can be done, we can save the ventilators and save the risk of intubations and basically avoid that. Next slide. All right, these are my references, mostly reference number 3 is important because it's very, very detailed in the number of guidelines that we just discussed a few of them. I wanted to thank all of you. You are the forefront of fighting COVID-19, and wishing you strength and health in these times. Thank you.
Hey, hello everybody. This is Dr. Sevilis. I'm going to take a little turn of pace here and talk a little bit more about the clinical impacts of COVID-19 on strokes. Next slide. I have nothing to disclose that would interfere with this presentation. Next slide. So some of the things we're going to talk about today is there are reports of changing stroke volumes, as well as the strokes in COVID-19 patients, whether it's a complication of the disease, incidental finding, and what the relationships are that we know. Strokes in young patients with COVID-19 has been a very hot topic of the moment, and we'll address that. What types of strokes that we're seeing in COVID-19 patients, as well as the use of antithrombotics in the COVID-19 patients that are hospitalized, as well as the impact that that has on our stroke patient population. Next slide. So starting off with stroke volumes, across the world, as Dr. Behravan has mentioned, that we've seen decrease in stroke volumes. It's been reported as high as 50 to 60%. And one study just came out on Friday, so it did not make it into the slide deck here, but I did want to mention it. There was a publication in the New England Journal of Medicine called Collateral Effects of COVID-19 on Stroke Evaluation in the United States. And in that study, they used the Rapid software platform, and they had 231,753 patients in the Rapid system at 856 hospitals. And they analyzed the data over the months leading up to COVID-19, so looking from February really through March, and seeing that over the 14-day period in which we had our peak, the rapid scans were down 39%, which means the patients presenting acutely in the first 24 hours who would typically use this rapid software, we were seeing nearly 40% less of them than we had right before this started. And that is some nice solid data for us as far as these acute presentations coming in, whereas a lot of these other volumes are a little more people saying what they see, which is important too, but there we can see that that drop is really real. And some of the reasons that we think this is happening is that those with TIAs or mild strokes and those who have improved quickly, they're not coming in. A lot of the stroke patients personally that I've seen are sicker than the average patient that I see. Their NIH stroke scales are higher. Now, that's not data, it's just personal experience. And I think that is because if you have a very mild symptom, people are afraid that coming to the hospital is going to get them sicker than the care they will get. There is also the thought of delay in care. So not necessarily directly that the symptoms aren't as bad, but that people are waiting to see if they go away. We know stroke patients do that no matter what. Unfortunately, some people do, but I think that's happening more often, and then they would be out of that acute time frame in which we could help them. The concern with this is that while even if it is the more mild strokes for people who have gotten better, that sometimes these mild events, TIAs, mini strokes, whatever you want to call them, can be a warning sign of something more to come. That a patient has atrial fibrillation or has another unaddressed medical issue that's putting them at risk for future, more devastating strokes. So it certainly brings up the concern of what our healthcare system is going to look like in a few months when these patients start coming in, and also what their individual futures are going to look like as a result of not seeking care due to the fear of getting infected with COVID-19 right now. So while I've seen many videos, many commercials, articles by all different hospital systems encouraging patients to come in and still get their stroke care, I think it's something that we need to really be very cognizant of and working towards, because we want these patients to know that we're doing everything we can to still safely care for them. And a lot of those ways were already mentioned earlier. And as EJ did mention at the beginning, we do have a community-based lecture that any of our hospitals, if you're looking to share something with your community, that we had done. Next slide. So, big question. Is stroke a complication of COVID-19? And honestly, we have very little data at this point. We're very limited in what we know about the exact relationship between COVID-19 and stroke. There's a lot of theories at this point as to how the virus itself could be leading to strokes. Some of those potential mechanisms that have been discussed are a sepsis-induced coagulopathy, is the one getting the most attention. It's associated with more severe disease in those hospitalized patients that are a bit further along. But we also are seeing strokes in patients that are completely asymptomatic of COVID-19 at presentation. Some of the lab findings in these particular patients are an elevated D-dimer and fibrinogen, and they can also have thrombocytopenia. There's a lot of other hematologic information out there that we won't be covering today. And then some of the other potential mechanisms would be cardioembolic. We do have heard reports of people having arrhythmias or severe heart failure, and these could also put you at risk for a stroke, as well as microangiopathic vasculitis. Next slide. So this picture here is from a paper that was recently published on sepsis-induced coagulopathy and kind of the theory of how that all works. So just to kind of go through this here, the SARS-CoV-2 virus binds to the ACE2 in the brain, endothelial and smooth muscle cells. ACE2 is a key part of the renin-angiotensin system, and it's the counterbalance to ACE1 and angiotensin 2. Angiotensin 2 is pro-inflammatory and vasoconstrictive, which leads to the end organ damage. So as SARS-CoV-2 is depleting the ACE2 receptors, this is leading to an imbalance in that system and increasing the role that the ACE2 and angiotensin 2 are playing, and therefore promoting tissue injury, which can lead to stroke through this vessel damage. Next slide. The other thing that we have to take into account when we're looking at mechanisms and reasons and thoughts about the association is the comorbidities of these hospitalized patients with COVID-19. These risk factors, these 5 are the main risk factors for having a severe case of COVID-19, but the top 4 we see there, hypertension, diabetes being the largest, are also our biggest stroke risk factors. And stroke itself, as was already mentioned, and cardiovascular disease are risk factors. So when we're trying to tease out, are these patients just coming from similar health risk factor groups and backgrounds, or are these truly causative events of the virus causing the stroke? We really don't have an answer to that yet. Next slide. And I think one of the biggest topics when people hear stroke and COVID-19, especially with all these recent publications, has been the risk of young people, being those under 50, having strokes due to COVID-19. I know right after these headlines came in, I certainly saw patients coming into the hospital with all sorts of thoughts and concerns about stroke at younger ages. Next slide. And the reason behind all those headlines was a case series coming out of Mount Sinai that was published in the New England Journal of Medicine about large vessel strokes that presented in patients with COVID-19. As you can see on the slide here, these are the 5 patients that they were reporting on. They were all in their 30s and 40s, and they all had large vessel strokes. And the point that they were making with this is that on an average 2-week time period, they would normally have 0.73 patients younger than 50 with a large vessel stroke, meaning they wouldn't even have 1 in every 2-week time period. And in this 2 weeks, they had 5. So that really stood out as a potential trend and something that is concerning to see. It's important to remember this is 1 2-week time period, and I'm sure all of us who've been on hospital services know that you can get little periods of trends. You can get times when there are more of one type of patient than another. So it definitely doesn't equal causative, but it's certainly a trend that we need to be keeping a close eye on. Next slide. And there, as I was just mentioning, the limitations of just one case series that we have on this. And the overall stroke volume that we're seeing is down. And if all of the strokes coming in are decreased, it's hard to believe that COVID-19 is causing this massive increase in young stroke patients, or we think we'd be seeing a larger amount of these patients coming into the hospital, which we aren't seeing right now. And I know everybody gets shocked when they hear about bad strokes in young ages, but it does happen, and it does happen all the time. A large vessel stroke in teenagers can happen. It can happen in children. 30s to 50s is certainly not our most common population, but we do see these patients all the time, and it's important to always be looking out for them, not just in COVID-19. Next slide. So the types of strokes that we're seeing in COVID-19 patients is another topic that we're going to talk about here. So the number of stroke cases that are being reported varies per studies that have come up in different hospitals, somewhere between 5 and I've seen as high as 11%. These are all, again, small studies that are being published right now. But the majority in all of these reports are ischemic strokes, both large vessel and small vessel disease. We do also have some reports of hemorrhagic strokes as well, and just an even more minority of them of being cerebral venous sinus thrombosis. The median time from onset of COVID symptoms to a stroke is 10 days, according to the study done out of Wuhan, China. But we also have these reports of strokes on presentation and no symptoms whatsoever beforehand. And I've seen some strokes as far out as in over 30 days reported too. So there is a very large range, and it is something we obviously need to be keeping in mind all the time while taking care of any patient in the spectrum. Next slide. We're going to go over a case report here that was recently published. So this is an 80-year-old female who had a history of hypertension, and she presented with altered mental status and left-sided weakness. She had no history of COVID-like symptoms, no fever or cough, and she was altered enough to require intubation for airway protection on arrival and had a code stroke activated. She was found to have a very low-grade temp there, 100.1. And she was not hypertensive. Her NH stroke scale was 36, and most of those points were for the left hemiplegia and aphasia. This was the one slide that they gave us of the CT scan, which you do not see a great right MCA stroke here, but we'll see that on the next slide. So if we can move on to that one. And so here on the left, we see in the angiogram, I can't point for you, but you can see there the right, over to the left a little there. Yeah, the left side there. That vessel on the left side is the right carotid artery, and then we can see it branches to the internal carotid artery, and which is occluded. The image up towards the top with the green and purple, for those who are not familiar with that, is the rapid scan. The green area is showing you the brain that is at risk for stroke, and the pink purple area is the completed or unsalvageable portions of the brain. So in this situation, those areas are very similar looking. If we were to see a lot of green and a tiny dot of pink, that's when we do interventions. In this situation, when they're pretty much matching up, this is a patient who was not a candidate for an intervention because their stroke was already completed. On the CTA of the neck, they showed some patchy apical lung opacities, which led to the patient being tested for COVID-19, and the PCR was positive. Some of the lab abnormalities that she had were leukocytosis, an elevated D-dimer, elevated lactate dehydrogenase, and an elevated CRP. She went on during her admission to develop AKI and progressively increasing oxygen requirements. So on day 3, the family had decided for comfort measures. Next slide. One of the other really big topics of discussion right now, not just in the stroke world, is COVID-19 and antithrombotics use. I have seen this hypercoagulability that's happening with COVID-19, and a lot of our colleagues, intensivists, have coming up with different ways to try to decide when to anticoagulate or what antithrombotics to start. And while we don't have studies to go off of like we do in so many other circumstances, people are working with what they have and coming up with various different algorithms to follow. This is one published algorithm from the Journal of Thrombosis and Hemostasis. And while right now we have no changes recommended or guideline treatment for stroke care, there's no prevention changes or treatment changes that we're making as a blanket statement at the moment. We do need to think about some of these pathways that our colleagues are using, because that does affect our patient population. And they have shown, the particular study that this algorithm came from was showing that there was some reduced mortality with the use of anticoagulation in the more severe COVID patients. And they're basing in this their decision as to whether or not to use aspirin or low molecular weight heparin based on if they have pneumonia and how severe it is. Next slide. And here is one other algorithm that Mount Sinai is using for anticoagulating. They again are kind of running through how severe the COVID symptoms are, outlining some specific high risk factors, and then deciding whether to use apixaban, enoxaparin, or a heparin drip by following through these steps here. And this becomes really important to us in stroke care because these very sick patients are also the same patients studies are showing are having strokes. And if our patient's having a stroke and they're on apixaban, well, we can't give them TPA. And that's something that is happening where a lot of patients who are having strokes, we can't actually use our typical acute stroke treatments because they are anticoagulated already. And it also leaves a hard position when a patient has both things going. If they have a severe pneumonia and they are in respiratory distress, and they've also recently had a large vessel, very large ischemic stroke, we now have to decide, do you anticoagulate them? What comes first, lungs or brain? Which one's worse? There's a lot of thoughts that have to come into these decisions, and there really is no clear right answer to those things. We're going to really just have to base this off of individual patient scenarios and how bad their respiratory standpoint is and how large that stroke is. Next slide. And this is the rest of the background on their recommendations there. There was no direct cite, as these were slides that are just published on the internet. So the link is here for anybody who wants to take a closer look at that algorithm. And one of the other challenges I do want to mention with these anticoagulation algorithms that are happening in the ICU is the hemorrhagic strokes that we see. I have not heard many or read any case reports on hemorrhagic strokes being the initial presentation with COVID-19. It has more been in the hospitalized population. And I think a good amount of this is the anticoagulants that are being used to help the lungs and the DVTs, the PEs, everything else that we're seeing that obviously needs to be addressed. And then kind of the collateral damage from that can be a hemorrhagic stroke in some of these patients, or if they had a ischemic stroke, having hemorrhagic conversion of that ischemic stroke. It also, being how sick these patients are, if they are intubated, sedated, prone, they haven't shown their signs of stroke, they could have an ischemic stroke during this time that turns hemorrhagic on the anticoagulant, and people not have been aware of it because of their overall condition. So there is a lot of interaction between both the treatments we're doing for COVID-19 and the neurologic risks that we have from that. Next slide. So just to review here, stroke presentations, at least in the acute time period, appear to have decreased, and we do have evidence for that across our country and across the world. And we should have a very low threshold to suspect stroke with COVID-19 patients, or suspect COVID-19 in our stroke patient population as well, and be testing these patients. We need more data to really understand this association and why and how it's happening. So the more tested patients that we have with stroke, the more we'll know the prevalence of COVID-19 in our stroke patients right now. This increased use of antithrombotics in COVID-19 population has a huge effect on our patient care, not necessarily in their acute presentation, but throughout their hospitalization. And it's something we need to be thinking about always. And we really need more studies. We need more information. We need to be able to get some definitive conclusions, and hopefully at some point be able to get some guidelines for management decisions. Next slide. There is certainly research going on, and people are publishing on a daily basis right now. But the one resource that I have heard of, if you are interested as a hospital in getting more involved in COVID-19 research, and not only stroke, but also in neurologic issues, the Neurocritical Care Society has a whole webpage just dedicated to COVID-19 research opportunities. And it was a few weeks ago, but at that point, they already had 55 hospitals up and running on getting data for all neurological issues and the impacts that COVID-19 are having on that. So certainly a good resource if you are able and interested in trying to help contribute to this research. Next slide. And here are some of the studies that I have referenced, or the backup to some of the facts that I've been giving you along the way here. I think that's our next slide as well. So if you're interested in reading more details. Okay. And lastly, I'd just like to thank all of the doctors, nurses, really everyone who's working in all the hospitals with us. We are so grateful for the great care that you're giving our patients and being that front line and helping move us around and keep our patients safe. Next slide. And we hope you enjoyed our webinar today. And the Educational Advisory Council will be continuing to put on more of these webinars. So we would love your feedback and helping us to make them insightful and meaningful and enjoyable for all of you. And now we'd like to open up to questions. And I will hand over to EJ.
Oh. Excuse me. We do have a few questions. So we have about 15 minutes left of the webinar. The first question is, what is making or helping the decrease of stroke cases? Is there anything that may play a role in this statistic? Dr. Sevilis, in the decrease, I think it's people not showing up at the hospital, not addressing their stroke cases.
Yeah, the main thing that is suspected, we have no data to say what it is that's making people not show up, but the concern is you talk to most people who are staying isolated in their home, hearing stay safe, stay home. If you were to have numbness in your hand for 5 minutes and you're like, maybe I should care about that, but it's gone now and I don't want to get the virus, I'm not going to go in anymore. I mean, I think that's a lot of what is contributing to this. The thing, and if you look at that one article that I had referenced, it does show that the presentations are picking back up again. And I think that initially everyone was too afraid to go anywhere and present at all if they were more minor or even some more significant, I'm sure. But the outreach that's being done, I think, is making a difference because we do see it turning back up in the last few weeks.
Great. Are you aware of any correlation with COVID patients having strokes and also being HIT, heparin induced positive?
I am not personally aware of, and the hematology literature that I have read hasn't specifically mentioned that. It may be out there. There may be some other studies. I focus mostly on stroke and only some of the hematology literature, but nothing that I came across had mentioned that.
Dr. Behravan, how about you? Have you heard anything?
No, I haven't seen a correlation. The thing is, I mean, it's a good point that it's going to affect what we can do for the patient. So if they're really, really thrombocytopenic, it's one of those cases that if it's just thrombocytopenia and it's severe, we can't TPA them. They can have thrombosis at the same time, thrombocytopenic. If they're not a large vessel and we can't TPA them, unfortunately, it's one of those cases that can't do much other than the diagnosis. But I haven't seen a correlation, but I'm sure studies are going to come out just comparing the statistics and see if there's a higher rate in COVID patients with HIT and stroke.
One thing just to add to that is, while not HIT specifically, I have heard of some avoidance of heparin and preference to the DOACs, particularly apixaban, as you saw there, because of some theoretical concerns of the effects of heparin on the inflammatory process and all these other systems that are going on. So there certainly is some avoidance of heparin, which may be why we haven't seen as much of that specifically.
Okay. Michaela has asked, has there been any research done yet on medications used to treat the impacts of ACE during COVID infection? ACE?
Not that I have seen. There's a lot of talk about the use of ACE inhibitors, and does that put you at more risk, and should people stop taking them? And there's nothing that has come out to say that that is the case and that you should. While it does affect this receptor, we just don't know enough yet. I'm sure there are people looking into it, but we don't have any good information at the moment.
Okay. All right. Next question: alteplase versus anticoagulation of stroke COVID arrivals. Does TeleSpecialists want to explore more involvement of the ED physician in the alteplase decision-making process in order to bring more comprehensive evaluation decision-making process?
So there are two important things here. One is that we try to minimize the number of healthcare providers involved in just facing the patient because of the risk of contamination. But there are 2 points. One is that we need to have as much information as possible to make the decision making on the alteplase. So if family is not allowed in the patient room, someone from that team doesn't need to be exposed to the patient, but needs to reach the family to get as much information as possible, considering that some of these stroke patients could be aphasic, some of them could be confused. So we may not be able to get all that necessary information from the patient. Now, regarding the anticoagulation, if they're deciding on doing the anticoagulation, and there's a suspicion for a stroke, we have to make sure that we have that answer before starting anticoagulation, increasing the risk of hemorrhagic transformation or hemorrhage, as Dr. Sevilis was pointing out to. So in that kind of decision making, yes. And also, if there is a patient with a stroke, I know that alteplase is used in some other indications. Well, we have to make sure that if there's a documented stroke, alteplase is not used when it's contraindicated from neurology perspective. So we do definitely need help in being proactive in getting as much information as possible and making the decision for alteplase and anticoagulation to minimize the risk of hemorrhagic conversions, but also providing the care that patients will need.
And I think it's a very large, probably a more significant role in which for the decision making is on our patients who are already admitted. I can tell you those cases I've been in on the intensivist have been right there, and I'm very grateful for that, because when these patients are hospitalized and there's a lot more going on here and a lot tougher decisions to make, we certainly need their input on the systemic care. I don't know that it's quite as crucial in that initial ED presentation, as the ED doctor isn't going to know tons of details on them that we don't already know. We'll all have the same labs and those things. So while we certainly need a team approach to this, I don't know that the alteplase specific decision is going to change from how we typically do it in that acute ED arrival setting, other than in the ways that you just mentioned for us there.
Great. Okay, the next question. Have you seen a positive D-dimer in COVID patients not having a stroke?
Yes.
Yes.
Positive D-dimers are in a lot of COVID patients and far more than we're seeing strokes. And I mean, PEs and DVTs are being reported more so than ischemic strokes are. And those patients would all have the elevated D-dimers too.
I think, another question would be, have we seen a not positive or low D-dimer in stroke patients with COVID? And that we have to look into.
That is a very good question. And every case that I've seen published has had an elevated D-dimer. But again, publication bias, and there's not that many published. So it would be interesting to find out down the line.
Good question. All right. Are stroke coordinators or leadership within your area doing anything special in regards to community outreach besides the marketing information on hospitals still being safe to come when someone experiences stroke symptoms? I know that as a company, TeleSpecialists, we've put out videos on YouTube, and we do promote it on our social media. But I'm not sure about specific hospitals in the areas.
I mean, I've seen various things, just come up on internet searches that are hospital specific and different hospitals trying to get the message out, or newspaper articles and things. But I don't know of anything other than those avenues.
Yeah, and I think once the report came out, or reports that the stroke cases have decreased, many facilities and my colleagues have tried to have some community outreach, whether through media or their own hospital, that strokes are still happening. So if you have stroke symptoms, you got to get to the hospital. Don't ignore the symptoms.
And I can say my social media feeds are full of that. So, but again, I follow a lot of doctors so I think I may see it more than the general public. But I think a lot of people are trying to get that message out there any way they can.
Absolutely. All right. The next question is, have you seen any preliminary data on the coincidence of cerebral sinus thrombosis in COVID patients?
I have seen it referenced, I think, 2 different patients throughout the literature I've searched in. So I haven't seen anything large on it. It's just was kind of briefly mentioned in papers that were talking about the incidence. And when you think about it, a DVT is a venous sinus thrombosis, or is a venous thrombosis, not sinus. and so the same way you can get the thrombosis in those veins, you can get them in the veins in the brain. I haven't heard this as a very frequent thing, but they aren't frequent at baseline. So I don't know that we'll be seeing a ton of them, or I hope we're not. But just very few case reports. Have you seen any more than the 2?
No, same that you've seen, and I guess it remains to be seen. More case studies coming out later as the cases compile. So, and we can definitely look into it in our own database, but we have to wait for more published papers to actually see if there is a definite increase in the cases or not.
Great. All right. Excuse me. Any specific follow-up on recovered COVID patients as it relates to stroke symptoms?
I was actually reading something interesting right before coming on here. One of my colleagues talking about seeing a lot of recrudescence in stroke patients. We see a lot of the acute patients, but for somebody who's seeing more telemedicine outpatient than the inpatient, saying that a lot of their patients are coming back with recrudescence. Now, we see that and for those who don't know what recrudescence is, that means a person's stroke symptoms that had resolved and gone away now coming back without actually having a new stroke. And that's something that we can see when patients are acutely ill with any virus, really, or any other major life-changing issue. Any systemic illness or anything like that can bring that on. So that is something that I think past stroke patients need to be aware of, is that if they get sick, they may start seeing some of those symptoms come back, and they should still get evaluated, make sure it isn't a new stroke, because that's definitely possible. But it may also just be the illness bringing back those old symptoms.
Yes. Now, one tangential things regarding this question is that there are some facilities that try to have a very close follow-up through telemedicine, but outpatient for TIA patients, trying to get all the necessary tests in the ER, and then discharging with proper treatment and having next day follow-up in the outpatient setting to try to avoid the admission, whether they don't have enough rooms, non-COVID, or just trying to decrease the contamination. That's one tangential point to this. And then in addition to recrudescence, I believe, with the potentially hypercoagulable state that these patients were in, and we don't know what for sure is going to work long term. There's definitely possibility of having another stroke even after patients are put on, for example, antiplatelets, and that may not be proven to be adequate if they come in with another stroke later on. Another follow-up that's important is because of the mental status changes. I know that it may not be stroke related per se, but we do see encephalopathy with COVID patients, COVID cases, and that is something to be monitored long-term to see if there is any long-term deficits in attention, memory, concentration, things like that related to COVID. Remains
just to add on to that, I've also heard of some behavioral changes, some not even a typical delirium, but ICU doctors reporting a beyond the expected delirium in these post-intubated and sicker patients. So there is kind of a question mark out there on, even without strokes, without any known true neurologic defined impacts, is there going to be some sort of cognitive or behavioral sequela of this disease that we have is possible, or at least people are reporting some early signs of that type of thing.
All right, great. And our last question is, we have heard the spores live for long periods of time on surfaces, such as does C. diff. Are there any studies that suggest that hand sanitizers are not as effective as we may think? It's not necessarily a stroke question, but it is a good medical question.
Not that I have come across. I feel like the non-direct spread of this disease, I see different things all the time. I assume sure everybody else does. I think the most interesting things that I was reading was how China has been doing these studies on it just living in the air and being in prevalence in doorways and places like that where people congregate. I haven't seen any concern that hand sanitizer works any differently on this as opposed to other things. So not to my knowledge.
Yeah, and I think another question, at least for me, would be that can this virus be suppressed and stay in a dormant phase and reappear later? And that would be a really real concern. We think that someone is cured or treated, and later on with whatever, if an immunocompromised state or whatever other cause, if it reappears, that's another concern.
Great. Well, I'm going to take this opportunity to wrap this up right before the hour is up. So Dr. Behravan and Dr. Sevilis, thank you both very much for joining us today. It was a pleasure having you and starting our webinar series. If anyone else needs anything, feel free to contact us via email or through the website, info@tstelemed.com. I'll be sure to respond to any other questions that you might have. Dr. Sevilis or Dr. Behravan, do you have any other comments or statements you'd like to make?
Thank you for having us. And again, thank you, everyone, for your fight against the virus and providing the best care for your patients.
Yeah, thanks for joining us. We hope you enjoyed it.
Thank you, everyone. Have a great rest of your day, and thank you for attending.